Thanks, Darren, and it's nice to be back in Geary today. So I'll just give you a brief overview of what we'll talk about for the next 40 minutes. I'll give you some key points about the Positive Ageing Strategy, which was launched in 2013, and then a background to the National Indicators Project, the results of which I'll present today. I'll talk to you about the consensus process and the Delphi technique that we've adopted for the project. And then I'll go through each phase and the results of each phase, how we measured consensus, how we analysed it, the participants that were involved in the process, and then some indicators that resulted from the process, and then situate our indicator set in an international, comparative international context. And then, as a sociologist, it's important to reflect on what you've done and how you could have done it differently. So I'll talk about some key points of going forward, what we could have done and what other people might think about if they were to adopt this approach. And then I'll summarise. So as a start, the positive ageing approach, which was adopted by the Department of Health in the National Positive Ageing Strategy, really focuses on the well-being of older people being affected by many different factors, including socioeconomic status, family, broader social interactions, employment, housing and transport, also social attitudes and perceptions of ageing. So this is quite different to some of the other approaches to ageing, like successful ageing, which is a more biopsychosocial model of ageing, productive ageing, which focuses on participation and employment, or active ageing, which again is more functional. So this is a far more holistic approach, and it really aligns quite well with the current WHO approach, which is based on capabilities, function and intrinsic capacities as well. So we're kind of at the cutting edge of these conceptual developments. These are the positive ageing goals and the framework. So there are four key goals. The first is participation, which looks at removing barriers to participation, providing opportunities for continued involvement, looking at cultural, economic and social life in Ireland. The second goal is health, so it's about supporting people as they age to maintain and improve or manage their physical and mental health and also their well-being. And the third pillar focuses on security, so it's about enabling people to age with confidence, security and dignity in their own homes for as long as possible. And the fourth pillar, which essentially constitutes the Healthy and Positive Ageing Initiative, is about supporting and using research about people as they age to better inform both policy responses and to population ageing in Ireland. And there are also two cross-cutting themes which are focused on combating ageism and improving information provision, because they're not the specific remit of any of those particular goals. So you see in the graphic we have these three pillars, but there are many domains within those pillars. So in participation we have employment and retirement, education, volunteering and active citizenship, cultural and social participation, and also transport as an enabling issue. For health we have healthy ageing, health and social care services, and also carers specifically. For security, it ranges from financial security to housing, age-friendly public spaces, safety and security, and also elder abuse. So it's a real blend of intrinsic capacity, well-being, structural and environmental factors. So broadly speaking, the National Positive Ageing Strategy and the HAPPY break down into two kind of structures. So we've got the implementation, which is the remit of Healthy Ireland, the National Health Strategy, and also Age Friendly Ireland, who are an NGO working in collaboration with local authorities to work at implementation at a local level. And then the Healthy and Positive Ageing research and evaluation work is led by the Department of Health. As Darren mentioned, it's a joint programme with the HSE, Age Friendly Ireland and Atlantic Philanthropies. I'm going to focus on the National Indicators Project, but in addition, we have a local indicators project, which is looking at the age friendliness of cities and counties in Ireland. And we have a research fund, which will fund additional once-off research. Those awards will be made in January 2016. And also we have the responsibility to publish a biennial report on the health and well-being of older people. So there's quite a lot of different moving parts to this project, but they are all very interrelated. So the indicators project, the objectives are to develop a set of national indicators that can be used to monitor positive ageing in Ireland, and the purpose of this was to map them to the positive ageing strategy for evaluation going forward. The method that we used was to develop consensus, so we initially established a long list of indicators, we revised and refined them through the consensus process, and established a core set of indicators which would be reported most frequently. And then the output is this biennial report. So there's two key definitions to this project, and first is a very technical point about indicators. So the positive aging strategy adopted the WHO approach to what is an indicator, a variable with characteristics of quality, quantity, and time used to measure directly or indirectly changes in a situation, appreciate the progress made in addressing it, and to assess the extent to which the objectives and targets of a program are being attained. Quite a mouthful, but very specific. On the other side, the consensus process. What is consensus? According to your dictionary, general agreement, the opinion of most people. So on one hand, you have something very, very complex and very specific. On the other hand, something very, very broad. So this project really wanted to reconcile those two. So for that purpose, we adopted a Delphi technique. And this is a group technique to build reliable consensus of opinion with a group of experts on a very complex issue. Arguably, aging is a hugely complex issue. The key features of the classical Delphi that we adopted is that there's a series of intensive surveys. You structure communication with your participants. You control the feedback that you give to them throughout the survey process between the different rounds of the survey. It's anonymous so that you don't get your responses don't get dominated by one group over another, which can often happen in a focus group. It's iterative, so you're deriving agreement and essentially a result. You were looking at statistical group responses, so we're taking a sort of an empirical approach to it, and we're looking at majority agreement and stability in responses on very specific issues. So we're in good company with this technique. It's been widely used in a lot of different countries in the health and social policy domain. In Ireland, it's been used to measure children's well-being, and the Office for National Statistics took this approach to developing their National Wellbeing Index as well. So across all approaches to the Delphi process, however adopted in the literature, we found that there were 5 general phases. So this is what we followed. The first is expert panel selection, then exploration of what indicators or issues you want evaluated, and then evaluation, re-evaluation, and final consensus. So the first phase, to identify our experts who was going to be part of this process, we went back to the original submissions to the positive aging strategy to see which groups put forward ideas and issues. We then went through publications and academic research on one or more of the pillars of the positive aging strategy. We shortlisted organisations, advisory panels and local authorities who were working on issues related to ageing. And then we also recruited from networks of older people, councils and alliances across different counties in Ireland. We invited these experts on particular issues to participate and to nominate other experts that they may know of. The exploration stage, so this was basically what indicators were we going to put into the survey rounds, and this was quite a detailed process. So initially we had published in May of 2015 a very long list, comprehensive kind of overview of all the existing data on particular issues in the positive aging strategy in a preliminary report, and that scoping exercise identified potential indicators and also gaps in the data framework in Ireland at the moment. So that initial list was about 130 indicators, and we developed a screening tool which basically the purpose was to set a minimum standard of quality for the indicators we put into the Delphi process. And those standards were derived from the literature on what comprises a quality indicator, the HICWA guidelines on what is a good indicator as well. So this screening tool covered four standards. First of all was the utility, the second was the technical merit of the indicator itself, the feasibility to collect and analyse the data for this indicator, and then the entire set was screened for balance and coherence, so where there are data gaps in that. So that indicator tool, while there's 4 standards, there's many different items in that tool, and it's available on our website as well, just as a resource. So after that, I think we had about 115 indicators which could be potentially included in our data set, and that went forward to evaluation in the Delphi process. So at this stage, we had the 3 rounds were an online survey. So in terms of evaluation through the first round of the survey, missing a slide, survey administration, I'll get back to that. How did we actually conduct the survey? We used an online survey platform as opposed to using paper-based survey, because this enhanced the coverage and the scope of who we could include. And it allowed us to monitor and track respondents, and then we exported the data to Excel and Stata, ran the analysis. In preparation for taking part in the survey, we gave every participant a very detailed information pack, which contained instructions, an FAQ, screenshots of what they would be navigating, and then indicator metadata, which was quite detailed. It gave the proposed indicator name, the data source, proposed disaggregation, and then further details on how that indicator was collected. We also gave them a copy of the preliminary report in case they wanted some more reading. There was many different options in terms of how you would manage your panels and this type of thing. You could have just one large panel where everybody would contribute, but that means that you have a lot of non-specialists kind of giving their opinion on something they may be interested in but really don't necessarily know about. So we went for a multiple panel approach, which was a little bit, it was unwieldy at times. It was a little bit more complicated. So we were looking at people opting into each pillar and responding on that. But it meant that people were really specialising in their area. And we did force responses to ensure that we had kind of complete cases to analyse. Some groups and some individuals opted for a paper-based questionnaire, and that was particularly useful for groups of older people who wanted to take part, and did so as a group, and I think that worked quite well, and they were quite pleased with that approach. So what did we look at in the first round of the survey? We looked at the importance of each indicator to positive ageing. So this was a little bit of conceptual work, and to make sure that this was actually useful to each group who were taking part. We also looked at, was this indicator needed and useful to national stakeholders? So would it be used? Was the indicator easy to understand? Because we wanted the indicator set to be accessible not just to policymakers or people working in implementation, but also researchers or anybody who's particularly interested in it. Especially if it's describing a population, they should really understand what's being said about them. Then we looked at the balance and coherence of each pillar, so security or healthy aging, and then the domains within each pillar. So within healthy aging, a domain might be health behaviour or palliative care. So we wanted to see, does this describe kind of the complete set, or are we missing something? We then asked the participants to rank the different indicators in each domain, which was quite a contentious thing to do, but it has been done in many different approaches across the globe. We asked them to rank the indicators because we would use this information at a later stage to inform what primary indicators we extracted from the main set. That ranking was tricky, but it was very informative, and it gave us kind of an indication of how people prioritise certain domains. Throughout every round, we collected a huge amount of open-ended feedback, particularly because this would help us understand why there might be disagreement on a particular issue or what was missing. And then in this round, we included a scoping exercise. This had not been included in the initial positive ageing strategy. They hadn't highlighted specific at-risk populations, but we wanted to scope out whether indicators should be disaggregated to at-risk populations or should there be specific indicators for those groups. So in terms of analysis, we screened each individual indicator at every round. We looked at the median response on a scale of 1 to 5, disagree to agree, on each criteria, whether it was important, useful, and easy to understand. In terms of consensus, we looked at group responses, and we looked at the median and the interquartile range here. So this has been sort of suggested as an objective and rigorous way of determining consensus. So if there was an IQR of 1 or less, this was consensus within a group and within the panel. If there was a median of 4 or above on an IQR of 1 or less, we included that indicator in round 2 on the basis that it was identified as being important, useful, and easy to understand, and there was agreement on that. For each domain and pillar, when we were asking respondents to look at each set, we set a threshold of 75% agreement for each set of indicators. And that's quite high compared to other approaches in different countries. Sometimes the threshold is above 50% and that. So we were aiming for a high standard to begin with. And in terms of the rank order, we just broke them into tertiles. So what was ranked, top, middle, and bottom. Then in terms of the qualitative feedback, because it was very detailed, we divided it into conceptual issues and actions that we could actually address in the indicator set. So we categorised and analysed this thematically. So briefly, this is the participant profile. So we asked each participant to identify from the outset what group they felt that they belonged to or represented in the process. And that allowed us to compare different groups. So we asked all participants to respond to issues on attitudes to ageing and information access. And then they opted into participation or security or healthy ageing. And then we asked participants whether they wanted to respond on these at-risk population issues as well. So to begin with, we started with 73 respondents for the cross-cutting themes. There was attrition across the different panels, but having analysed it, we're not too worried about that, but it is expected over time. So these are the results. I'll just go through the ranking first because it's sort of brief and it's kind of interesting just to show that there was quite a difference in how people prioritise different domains for healthy ageing. So it was really dominated by physical health and brain health and positive mental health. And then end-of-life care and carers was kind of ranked low, but we're not quite sure why that would be, but we feel that there might be the case that the order that we presented things could have influenced a little bit the order that people left or didn't change them in. But the next one was on participation. So top ranking was really social and cultural participation, employment and retirement, followed by then transport, education, lifelong learning, and active citizenship and volunteering. And from security, personal safety, so feeling safe in your environment, in your home, in where you live, really dominated the ranking there, then followed by financial security. And interestingly, age-friendly public spaces was quite low, but we felt that people found that very difficult to understand as well. So I suppose because the ranking happened at the very beginning, we can look to some of the other measures that we used to try and understand why that might be ranked low. Then in terms of attitudes to ageing, this was quite a diverse and sort of emerging kind of measurement domain. And the ranking, we put a lot of different indicators in this because it was, I suppose, conceptually the least well-developed cross-cutting theme or issue in the positive ageing strategy. So we really wanted to kind of do some conceptual work here and try and understand what matters. So broadly speaking, you could break the ranking down into very tangible things like treatment and experience, followed by self-perceptions of ageing. And then the ranked lowest was actually issues around intergenerational solidarity. These are some indicators from Eurostat, I think, or maybe the EQLS, but they're about tension in society. So again, something that people might not really identify with. So I suppose there's some work to do about what are we talking about when we say attitudes to ageing. And then in terms of the ranking for information access, there wasn't exactly a clear pattern or sort of ordering to the themes in this. But top ranked was not receiving community care due to a lack of information. So that was sort of information provision. Internet use, again, is more provision. The health literacy indicators, some of them are ranked highly, others low. And generally sort of health promotion, disease prevention were ranked lowest. So 49 participants opted to take part in the at-risk populations section of the survey. And this basically posed the question, should there be separate positive ageing indicators for, we suggested, Irish traveller community and people with intellectual disabilities. So there was a high level of agreement that, yes, there should be a separate indicator set for them. And we proposed some potential indicators for these. So percentage of Irish travellers with a chronic illness, mortality rate per 1,000 travellers aged 45 plus. And these are because there was a huge difference in the mortality rate and the prevalence of chronic disease between the Irish traveller population and the general population. And for individuals with intellectual disabilities, we looked at self-reported doctor-diagnosed chronic conditions, individuals with medium and high levels of physical activity, and individuals who report that their emotional or mental health was very good or excellent. So they were the proposed indicators, and again, there was quite a high level of agreement that they were should be included. Other open-ended feedback suggested that there were other populations that should be looked at. I've highlighted older adults living alone and carers in that because while they were suggested in the open-ended feedback, they're actually included in the strategy and we're also in the disaggregation of a number of different indicators. So I think it just highlights how salient that is to a number of the participants in the process as opposed to them overlooking what was already there. LGBT was also included, migrants, prisoners, homeless individuals, and older adults currently in institutions or with experience of institutionalization in their life. So these are sort of the at-risk populations that participants felt should be looked at as well in more detail. The open-ended feedback I mentioned was sort of conceptual and then action-orientated. So just to highlight some themes that came through in the more conceptual points, there was images of aging, equality of access, opportunities for lifelong learning, autonomy, and health systems as well. And then specific technical feedback, we looked at things like revising the terminology, and then specific disaggregation and changes to indicators. So after round one, we made quite a few changes to the proposed indicator sets on the basis of consensus, ease of understanding, ranking, and open-ended feedback. So where those didn't meet the criteria that we'd set out, we included some new indicators where there were gaps. We changed a number of indicators, particularly in the healthy aging domain, and that was really based on some very tricky wording and it was a little bit difficult to understand, I think, for a lot of people. And also, healthy aging was really the set that most people opted into. And it was also the indicator set that had the most indicators in it. Yeah.
Sorry, participants who did the survey, were they, or what age were they? I mean, what age groups were they? Were they older people or were they every age group?
They were every age group. We didn't collect their actual age.
So you don't know the mean age. I'm just wondering how many of the people who were completing this is applicable to, as in they are living it, they are old, you know, versus people who are thinking about being old.
Yeah, like there's a whole range. So from the sort of academic and groups and people working in sort of local authorities, voluntary sector. I mean, there's sort of working age, but there was a number of students who took part, PhD students who had worked in a particular area, researchers, early stage researchers as well. So, but right up to groups of older people, councils, CEOs.
And you look at the results by different people, like different groups. So you
yeah.
can imagine academics will be a very certain way, and
yeah.
the older age, say the participation groups and those.
Absolutely. So when we looked at ease of understanding, we compared academic and non-academic and agreement by each group as well as by panel. So we looked at sort of heterogeneity within the panel before we I agreed there was consensus on that. So yeah, there's a lot of sort of background work on that, but we didn't actually collect their age. Limitation, I guess. So the next round of the survey, we carried forward the importance of each new indicator and ease of understanding of each new or revised indicator. And then we asked the participants to give their opinion on the sort of balance and coherence of each domain, and then again collected open-ended feedback, which was particularly useful where they disagreed with a particular issue. So at this stage, we removed 4 indicators because they weren't seen as important. 2 of those were indicators which were new or carried forward. Easy to understand. We looked at 25 to 30% of the panel had difficulty with 12 of those indicators, and they were reworded, and we did break it actually down by academic, non-academic. Also, as happens, data becomes available all the time. So the quarterly National Household Survey published their equality module. So we aligned some of the indicators we had on experiences of discrimination to that new data, and then asked participants to give their view on that or where they agreed with that change. And then we also made some very specific adjustments to the age disaggregation and the reporting style of those indicators. We added 2 additional indicators on blood pressure checks and emergency inpatient admissions on the basis of some very high-level advice from experts in the panel. So then the final consensus round, we looked at balance and coherence of the pillars and the domains on the basis that the individual indicators had been agreed, had been useful, important, and then we looked at agreement with the set of primary indicators. So this is where the ranking information came back into the process. So this looks at round 2 and round 3 and just the level of agreement with the fact that this pillar or domain represents a complete picture of the particular issue. In Ireland, we looked at people who either agreed or strongly agreed with that. So for the cross-cutting domains, we went from 74% to 78%, information access 70 to 73%. And just to highlight, there's three areas where consensus really wasn't achieved at that 75% threshold. And interestingly, in particular in relation to housing, we had 91% agreement with that pillar, and that went down to 71%. And then for brain health, we went from 80 to 73%. So we went back into that data to find out what was kind of going on. So, as I said, in round 2, attitudes to ageing and information access fell below threshold for consensus at 75%, and they both increased in round 3, one above that threshold. So for information access, housing, safety and brain health, they were below the threshold of 75%. But for those indicators, there was no change between round 2 and round 3. So you have the same people looking at the same thing, 2 different points in time, and rating it differently. So we wanted to find out what was going on. So we collected, as I said, a lot of open-ended feedback on this. And we found that within the specific groups, there were a very small minority who disagreed with the selection of the primary indicators for those areas. So we feel that presenting something as primary might have influenced whether they felt that that was reflective or not. And then if we looked at their open-ended feedback, we found that really these individuals wanted everything in. They just wanted everything in, which is fine, because it's difficult to say primary versus secondary when it's perceived as some sort of prioritization exercise, and it's not. So I suppose we take that change and sort of dissolution of consensus between those two waves with a pinch of salt, and we have really sought to understand why that could happen, both in the survey structuring and also in the qualitative feedback. But overall, we did find a high level of agreement with the primary set. It ranged from 75 to 92%, which is, again, in comparative context, that's a really high level of agreement. Information access does remain a very evolving domain. We hold our hands up with that. It's quite conceptually, it's quite slippery, and it really is about striking a very fine balance between provision and then individual capability to evaluate and apply information. So developing individual capacity at the same time. So really striking a balance there in implementation will be key. So just to give you a little flavour of some of the indicators that we're going to publish in January. So for attitudes to ageing, we've looked at discrimination and then a component of quality of life, which looks at perceiving ageing as a time of personal growth. So that's a personal approach to ageing. And then for information access, we've looked at internet use and also difficulty understanding and acting on health information. So that's health literacy by any other name. In employment and retirement, we've looked at the employment rate, education and lifelong learning, formal education, informal education, literacy and low numeracy. So again, participation and individual capacity. Active citizenship and volunteering, we've looked at political activities, unpaid voluntary work, and providing care. This is a short list. It's a lot more detailed than this. This is just a flavour. For financial security, we're looking at the poverty rate and then also the lived experience of that. So a shortage of money stops them from doing things they want to do. This again is a component of quality of life indicator. We've looked at housing facility problems, housing conditions, and also an item from the deprivation index made it through to the housing component here. So percentage of households who are unable to keep their house warm. Age-friendly public spaces, we've looked at difficulty accessing essential services and also social facilities, recreational facilities and green areas. And in safety and security, we're looking at safety in your area, so safe to walk alone after dark, safe alone in their home at night, and then also a number of confirmed cases of elder abuse. So it's quite a broad approach. And then just 4 domains from a very exhaustive list of domains in healthy ageing. So for brain health, we have the percentage of people 50 plus who show evidence of mild cognitive impairment. For positive mental health, 2 indicators here are moderate and severe levels of depression and a sense of control and freedom over their own lives. For physical health, just an indicator here, healthy life years at age 65 and also falls in previous years. And for palliative care, we've looked at specialist palliative home care nurses per 100,000 of the population, and then also specialist palliative care beds. So more of a process indicators there. So how does the happy indicator set compare to other ageing indicator sets? So currently there are 8 indicator sets worldwide, but that number is going up and up. There seems to be a real buzz around this kind of approach. So there are indicator sets for Europe. There's a global age watch index. New Zealand have a positive aging index. The WHO are developing another indicator set. The Netherlands have one, and the US have two. One is US specific, and the other is multi-country, including a lot of countries in Europe, actually. So social engagement, employment, financial security, housing, physical health, very, very common features across all of those different approaches. Attitudes to ageing is actually only really present in our set and in the New Zealand positive ageing indicator set. That makes sense given the conceptual background. End-of-life care only exists in our set, and the Netherlands values on the grayscale indicator set. And then unique features in the happy indicator set are health literacy, these personal age perceptions, and sexual health as well. So, given all the different moving parts and the time frame that we had to do it, what would we do differently if we were going to do it all again? First of all, the survey length. While it did reduce across the two waves, as we kind of looked very rigorously about what we would include and what is really necessary, it was very exhaustive. It took about 2.5 hours, I think, upwards at times for some individuals, days maybe. But with the Qualtrics software, people were able to dip in and out as they went, and we really worked with people on that, and we were able to leave certain surveys open for longer and close others. So it's about responding to your group and supporting them in the process. We could have done a little bit more work in the pre-survey stage. We could have had an expert advisory group who that's been an approach in other settings to kind of really cut down that long list of indicators. After the Delphi, we could have done that kind of work with a group to establish the primary indicators, but we really wanted to, given that we had a very motivated and a very skilled sample, we really wanted to put it to them and get their consensus on it, given that so many of them would also be involved in implementation and using the data. The time of year, it wasn't ideal. It was July to November. That's a very difficult time to collect and expect people to sit down at a computer for a long period of time to collect that data. But you have to be pragmatic, and that's what you're faced with. The ranking was particularly contentious. A lot of participants did query or wonder if this was, I suppose, a prioritization exercise for implementation. So I think we had to, if you were going to do this, you really should be even more clear to them that this is not, how often we would report the indicators and which would be primary indicators. It's not about implementation. So I think that's difficult when you have a number of different stakeholders involved in the program. And then also, compared to other countries, are we looking at having a set or an index? And there really is, indexes are really in at the moment, so I think the Stanford Center for Longevity Index of Wellbeing of Older Populations, quite a mouthful, they have data for 12 countries, and they have some very nice methodology around constructing indices of material, physical, cognitive, social, and emotional well-being. So it's possible that we could take that forward actually with the data that we have. So in summary, the Delphi process is considered to be rigorous and transparent in identifying and agreeing indicators, and we've used some very detailed quantitative evidence of consensus for that purpose. It has been a hugely inclusive process, and although I haven't presented the feedback here, it has been really positive from the participants, and we didn't round too many people off with it, so that was quite nice. And they did find it worthwhile, and they agreed. We're very happy with the process in general. Because we used an online survey, we could include a wide range of participants, and that really got over a lot of the kind of bias that you would include if you had just a focus group. We did achieve a lot of accessibility, and we feel that we've measured what people really think is important to positive ageing, and that's because throughout the process we were very reflexive about that conceptual work that came through the qualitative feedback. We did achieve a high level of agreement. We have 56 primary indicators across 20 domains, and they do link directly to action points in the positive ageing strategy, and from the outset they met that minimum standard for what makes a good indicator. We will do some more work on information access, and we'll report the entire consensus process, the indicator set in January 2016. The first data report will be in March 2016, and then we'll have a series of themed research briefs for indicators that met that threshold and were agreed on in the process but weren't in the primary set. So that will continue from 2016 through to the end of 2017. So that's it for now. Thank you.